some of you might be familiar. There was a study, Hokusai Cancer VT, which was published in New England Journal in February of 2018, which showed non-inferiority of edoxaban compared to dalteparin. So you could probably make a case for using edoxaban in those circumstances, yet it's not FDA approved for that indication. If somebody doesn't want to be on injections, enoxaparin or dalteparin, I think edoxaban would be reasonable in those circumstances, cancer-associated VTE. DVT of the leg or PE without active cancer, I think DOAC would be a preferred anticoagulant. Valvular fibrillation, valve replacement, myocardial infarction requiring dual antiplatelet therapy, women who are breastfeeding, I think these are not safe. These are the indications where you should not be giving DOAC. I think warfarin is still preferred anticoagulant. There are other conditions like antiphospholipid antibody syndrome where there's questionable risk, increased thrombosis with DOACs. So that's another indication where we should not be using DOACs. So then comes, when should we be using? Non-valvular atrial fibrillation, secondary VT prevention, VT prophylaxis following major surgery like knee or hip replacement surgeries, patient able to pay. Affordability is a major issue. Even at this time and age, affordability is a question that comes up. If the patient can afford, has a good insurance coverage and approval of the medication, their kidney functions are normal, the liver functions are normal, not significant drug-drug interactions, you could choose DOAC. If the answer for these, no, the kidney functions are normal and they have other contraindications, I think Coumadin would still be a preferred anticoagulant. So if the patient is aware of all the other nuances like the compliance or non-availability of a specific anticoagulant, then they don't want to come back, frequent monitoring of the medication, lifestyle issues and all those things, DOAC could be an ideal anticoagulant. So these are a little more nuances of how do you prescribe. For rivaroxaban, non-valvular atrial fibrillation, 20 milligrams per day is the standard dose. Apixaban is 5 milligrams twice a day. For DVT-PE, there is a loading dose of 15 milligrams twice a day for about 3 weeks with rivaroxaban, 10 milligrams twice a day for about a week, and then you switch them to 20 milligrams of rivaroxaban daily versus 5 milligrams of apixaban daily. So that's something to be familiar with. Whereas if you choose dabigatran or edoxaban, you see that for DVT-PE, you have to bridge them. You have to start an injectable anticoagulant for at least a week and then switch them to dabigatran or edoxaban. Now, renal dosing. This is another thing which comes up very frequently. Sometimes the patient's kidney functions fluctuate. For rivaroxaban, if the kidney function is less than 50, between 15 and 50, you would go with 15 milligrams once a day rather than 20 milligrams. That's in patients with non-valvular atrial fibrillation. If there is the creatinine clearance is less than 15, probably not a good idea to give them the direct rivaroxaban or the direct oral anticoagulants, any of them. I would probably not recommend using in those circumstances. So here's the dose reduction for dabigatran. Between 15 and 30 mils per minute of creatinine clearance, use 75 milligrams twice a day. And if it's less than that, probably use Coumadin. How about liver dysfunction? If somebody's Child-Pugh score is category A, no dose adjustment required for rivaroxaban or apixaban, but category B and C, I would probably avoid using. And that's a whole different topic. It's very challenging how to anticoagulate patients with chronic liver disease. There is some safety data using dabigatran in category B, Child-Pugh chronic liver disease, but you should probably try to use warfarin. There is also some safety using a low molecular weight heparin like enoxaparin at a lower dose, probably starting at 0.75 milligram per kilogram. But remember, when you see those patients, the mechanism of action of heparin or heparinoids is through antithrombin, and there will be lower level of antithrombin in these patients, sometimes less than 50%. So these anticoagulants may not be effective in those patients. So drug interactions, almost all of these medications have P-glycoprotein as a substrate, And most of the anti-10A medications use CYP3A4 for their metabolism. Now, these are the ones which you should be very careful. Definitely take a look when somebody is on anticonvulsants, including barbiturates, antiretrovirals, antifungals, particularly fluconazole, antiplatelet drugs, and NSAIDs. That I put it in red because of the increased risk of GI bleeding. And then tyrosine kinase inhibitors. Off late, most of the patients with cancer, they are on targeted therapies, tyrosine kinase inhibitors, monoclonal antibodies, which can interfere with these anticoagulants. So key points, patient selection key points. Low molecular weight heparin is still preferred in patients with active cancer. DOACs are preferred in patients with DVT-PE. Non-valvular fibrillation. If you look across the recommendations from different societies, European and Canadian guidelines, even the ACCP guidelines do favor using DOAC, whereas the Heart Rhythm Society, ACC, AHA have not recommended one versus the other. They would say you could pick Coumadin or the DOAC. Do consider patient comorbidities and their ability to afford the medication. Those are important considerations when you prescribe this. Now quickly, how do you do oral anticoagulant switching? Not very complex. I kind of broke it down into two things. Coumadin is one thing, and then non-Coumadin. When somebody is on low molecular weight heparin with relatively similar half-lives, you just stop low molecular weight heparin and then start the DOAC when they're due for the next dose. So that's simple. And same thing, when you want to switch them to low molecular weight heparin, you stop the DOAC, and when they're due for the next dose, you start the low molecular weight heparin. Unfractionated heparin, the half-life is relatively, very quick, in few minutes. So you start the heparin, the infusion of heparin, and then you start the DOAC at the same time. And likewise, when you stop the DOAC and when you want to switch them to the IV heparin, when they're due for the next dose of DOAC is when you start the IV heparin. The challenging thing is with Coumadin. There's not, I don't know if there is any evidence, why apixaban you have to wait until the INR is less than 2.0, whereas rivaroxaban INR less than 3. But you can see that it has to be in the therapeutic range or below the therapeutic range before you switch. It might take a few days, probably about 3 or 4 days. So you probably monitor the INR day 3 or day 4, and once it's below that range, you could switch them to the DOAC. Now, switching DOAC to warfarin, it's a little more, that's something you have to pay a little attention. They might need a little bridging at that time. You could either continue the DOAC once they start warfarin, and make sure the INR is therapeutic, stable for about 2 or 3 days, and then you can stop. Essentially how we do with the unfractionated or fractionated low molecular weight heparin. So bridging and periprocedural management. There are a lot of guidelines about this, but my practical advice is talk to the surgeon and always assess what's the risk of the bleeding of the procedure. That's probably going to guide most of the, the periprocedural bridging. And we also talk about, I'll show you in the next slide, there was a trial just published a couple of years ago called as the BRIDGE trial, which showed that patients who are on chronic anticoagulation due to atrial fibrillation, you can just stop it. They probably don't need bridging. And the difference between the two groups were not any different for patients with atrial fibrillation. So, apart from talking to the surgeons and assessing the risk of bleeding, one takeaway message is if they're on low molecular weight heparin, don't start them at the same time. Don't overlap. The risk of bleeding will be so much higher. You're potentiating the anti-10A pathway, and they're at a significant risk of bleeding. So if somebody has an acute DVT, which is preferably 3 months of anticoagulation at least, or maybe 6 months, it's ideal if you can delay the elective surgery until then. If it's an emergent and urgent surgery, that's a different situation. But if it's an elective surgery, please wait until they've completed those 3 months of anticoagulation. And I always, have a risk table. I've printed this table and have it on my, board, which I quickly refer to, and I'll show you in just a little bit. Now, again, keep an eye on the kidney functions, which is an important thing when you're doing the, periprocedural anticoagulation consult. General rule of thumb. If the surgery is low risk, you hold it for 24 hours, sometimes 48. And you can, if it's a high risk surgery, high risk for bleeding, then you hold it for 3 days, 72 hours. That's kind of the general rule of thumb. And when do you restart? About 24 to 48 hours, again, depending on the risk of rebleeding post-surgery. And here, this is how it works. You don't need bridging with low molecular weight heparin because the half-life is essentially is similar between the DOACs and low molecular weight heparin. On the top, you see Coumadin, where you need the half-life being long. You have to stop at least 5 days prior and then bridge, and then you stop a few hours, 12 hours or so, 12 to 24 hours prior to the surgery. Now, this is the table I was referring to. This is another cheat sheet. You should probably have it handy, looking at what are the procedures which should be considered high risk, low risk, or minimal risk. But ultimately, it comes down to the comfort of the surgeon. I've seen these kind of switching back and forth. I've seen colonoscopies considered high risk sometimes. So this was the study which came out back in 2015, kind of is changing the landscape of how do you bridge in patients with atrial fibrillation on anticoagulation with Coumadin. This study, as you can see, they used dalteparin versus placebo for about 5 days, and then here's the surgical time, and then they resumed the same thing depending on the risk of bleeding either 12 hours or 24 hours after the procedure was done. And ultimately, when they looked at the results, they did not see any difference in the risk of thromboembolism between the placebo group versus the dalteparin group for bridging. And obviously, the risk of bleeding was higher with dalteparin. So if somebody is on stable anticoagulation for atrial fibrillation with Coumadin, you can use this evidence to say that these patients probably don't need bridging when they undergo any kind of procedures. Again, we all live in the world